So, hello everybody. Time is actually 1 o'clock for at least some of us, and we should start at 1 o'clock sharp. So I will start share my screen. I would just say that I am Catriona. I'm a professor of palliative medicine at Lund University in Sweden, and I will see if I can start my screen to make a little bit more of this presentation. I wish you all welcome to this webinar, Families' Perceptions of How We Care for Their Dying Relatives. And we have two invited great speakers, Professor Peter Hudson from Australia and Dr. Catriona Mayland from the UK. And the first one will be assessing quality of care for people dying of cancer in hospital, development of the QoL-Death framework. And then this will be followed by Catriona talking about what we can learn from the voices of bereaved relatives. And this is interesting because I can't go to the next picture.
Do you want me to share, Carl-Johan?
Yeah, I think you should share because there's something funny going on.
Just bear with me.
So this webinar is an activity from the international collaborative Best Care of the Dying Person. And we are a network of people from the six continents of the world, and we have 253 members now. And you can take the next, please, Joe. And our vision that we work with is a world where all people experience a good death as an integral part of their individual life, supported by the very best personalized care. That sounds good, doesn't it? Next, please. And what we do, we have a program including a clinical part, which is based on what you call the 1040 model of best care for the dying person. And in that, you can see that the focus of the collaborative is more on dying and the last phase of life rather than early palliative care and integration of that into mainstream medicine. We also have in our program research and development, learning and teaching, and quality assurance. Next, please. No other way, I think.
No, I think that is it, Carl-Johan. It's
That's
just now.
Yeah. I say more later.
Yes.
So I will now introduce our first speaker, and that is Professor Peter Hudson from Australia. And Peter is a registered nurse, and he has been working for more than 30 years in palliative care research, education, and clinical practice. And he is now the director of the Center for Palliative Care, which is an academic department based at St. Vincent's Hospital and a collaborative center of the University of Melbourne in Australia. And by those words, I introduce Peter, and you can start sharing your screen. And there is just one thing I would like to say before Peter starts, and that is that we're happy to have your comments or questions on the chat so we can see what's going on, and that you're welcome to share that during the talk, and then afterwards we will have a discussion based on that, and probably also other questions. So please, Peter. Well, thank you very much, Peter, for this interesting work and ambitious work, I must say, that you're doing, and that could influence a lot of what we do, with different perspectives on trying to meet the needs of the dying. I hope that you don't forget to put questions also in the chat, so that we can use them later on. But now I would like to introduce our next speaker, Dr. Catriona Mayland. And Catriona from Sheffield University, she is currently completing a senior research fellowship at the University of Sheffield. And Catriona has more than 15 years of experience evaluating quality of care for the dying, working with the bereaved relatives to gain their perspective. And she's behind the development and validation and use of the care of the dying evaluation, the CODE tool. Clinically, Catriona works at Western Park Cancer Centre in Sheffield. And welcome, Catriona, and you may, of course, introduce yourself better than I could, so feel free to add anything you want. And we'll see if your screen sharing is working. Fantastic, yes, very good, please. The screen is yours.
Thanks very much, and thanks for the kind invitation to speak today. Yeah, I'm Catriona Mayland, and I'm based at the University of Sheffield. And I wanted to speak about what we could learn from the voices of bereaved people, and particularly in relation to end-of-life care. As we know, by seeking these views, they can help provide assurance about the quality of care that is provided. They can help identify what areas require improvement and can allow benchmarking between different organisations or different countries even. And in some ways, they provide an impetus for ensuring that healthcare and care very much at the end of life is provided to as high a standard as we can achieve. So in this talk, I'm briefly going to give a very quick overview of surveys involving bereaved people and think about what we can learn, drawing mainly on the research that I've conducted with Care of the Dying Evaluation, or CODE. I want us to consider why bereaved people might participate and their motivations and the impact it could have, and think about then how we use what they say in feedback to improve care. So firstly, just a brief overview of surveys. To my knowledge, the most seminal work began in the late 1960s, which was conducted by Cartwright in England and Wales, and was published in a short book called Life Before Death. Cartwright undertook a nationally representative sample and conducted interviews with individuals about what the last year of life had been like from their perception. The interviews tend to be conducted 3 to 9 months after death, and they got quite a remarkable response rate of 82%. When you look at the methods that they used, though, that did include directly visiting the person who registered the death at their own home, and also, if that wasn't successful, also visiting the address of the person who'd actually died. And on reflecting about that, I did think, certainly in the UK, ethics committees would not give that approval these days, but it was quite remarkable work at the time. And the main finding from that piece of work was about the need to kind of increase the number of end-of-life care services and also think about how services are coordinated, a message that in some ways still resonates very much today. Since that initial work, though, there's been much more research and surveys conducted in this area. And this map is just to show some of the findings from the National Care Experience Programme, which is an Irish organisation made up of the Department of Health and the Irish Hospice Association and other organisations, where they conducted a review about which countries had undertaken national surveys. And you can see that they've highlighted particular work from the USA, from Japan, and from New Zealand. And within the UK, there's also been a number of national surveys. And one I wanted to highlight was the National Care of the Dying audit in hospitals, where Care of the Dying evaluation was used. but there's also been other ones such as Voices and a quality survey. Further, there's been a systematic review looking at the different tools that assess quality of death, dying and care. And in total, at the time of this review, there was 67 different tools, of which 4 were recommended based on their psychometric properties. And again, one of these was the Care of the Dying Evaluation, or CODE. So CODE very much focuses on the last days of life. Its key outcomes are about how much time someone is treated with dignity and respect, and how well the family is supported. And in total, there's 32 question items about different aspects of care, including medical and nursing care, communication, emotional and spiritual support, and the actual care at the time of death and immediately afterwards. Further to this, there are demographic questions and also free text space, so that the bereaved people are able to leave additional comments or thoughts or reflections that they wish to share. The initial validation was undertaken in England with those who died at home, and then the CODE questionnaire was further validated on an international level within a study that was conducted in hospitals with dying cancer patients who were within specific sites in 7 European or South American countries. So then, reflecting back about what can we learn from the bereaved people and the work that I have done with CODE, because CODE is being used at sort of local and regional level, but also national and international. And I'm going to just take a two-pronged approach about thinking about the broad messages and then some more of the detailed picture that we can get in addition to the question items. So this first broad kind of theme is about unmet communication needs. The study was conducted in the UK hospital setting. Just under 900 next of kin undertook the survey. And in particular, what we see, not just in this study, but in subsequent ones, is that discussions about fluids at the end of life and about what to expect when someone is dying remain persistently unmet communication needs that we need to try to address. And we saw that actually aspects of communication were even more heightened during the COVID-19 pandemic and the height of this. And this was a study within the UK, but linked internationally. The UK was all healthcare settings and just under 300 next of kin. And again, we saw issues in terms of communication, that meaningful explanations and being involved in decisions were areas which weren't fully addressed. And actually some of the results were poorer compared to previous comparisons using CODE. And this is particularly relevant because of the restrictions that were in place. And actually the learning from this is no matter what kind of restrictions are, we really need to focus on trying to ensure people are kept updated using novel and diverse ways. As a sort of effect of this, that sometimes we can see that influences the overall perceptions about where people died and what people thought. So this was the international study that I talked about that involved hospitals within 7 European and South American countries. And there was just over 900 participants. Again, we see some issues with communication, that although people were frequently told their relative was likely to die, there was still unmet needs in terms of that, what to expect when somebody is dying. And when we looked at this more carefully, we could see that that had an influence about where the person died and what the perception was. So of those who said they were adequately supported, they were more likely to respond to that, give that response if they died in a palliative care unit within the hospital rather than any of the other hospital wards. If we look at more detailed from the same study, my colleague, Dr. Christina Gerlach, led on this piece of work where she was specifically looking at the free text comments that were left within the code questionnaire. So as I say, there was over 900 completed code questionnaires and over 450 participants left free text comments. And with this, we both looked at the content of what additional information people provided, but also the way in which they gave the feedback and what that potentially could mean. Epistemologically, we used an approach of subtle realism and framework analysis to conduct the analysis of the free text comments. I'm just going to give a couple of examples of the content of the free text and what it added in addition to the questionnaire items that are contained within code. One of the key messages is about the fact that one person can make such a difference in terms of perceptions. And that can both be a very positive experience or equally a very negative one. And to us, what the learning I take from that is that we each have an individual responsibility of thinking about how our communication, how our attitude can actually have quite a profound effect on the perceptions of care. A second example of a content of the free text which went above the questionnaire items was the importance of actually being a companion to the dying, being present at that time of death. And again, you can see from the very positive example that actually there was clear communication so that people, the family, were able to spend time in the last days of life. By contrast, where this hasn't been possible, where people haven't been informed, it's a real missed opportunity and can have quite a profound difference on that individual. So then, again, looking at why the bereaved relatives may participate in these types of survey and building on findings from that previous study, just having a think about the motivations and the type of feedback and how this might link with bereavement theory. So within the free text, there was a number of different types, 3 main categories: feedback, narrative, and self-revelation. The feedback could be both positive in terms of gratitude and praise, but also could be critical, either a direct complaint, a comment about the impact and the burden that it had, or a direct call for an improvement. The second type of free text was the narrative. Now, this could be in terms of chronicling the details about the specific events or witnessing a moment. This links with sort of Tony Waters' work in terms of grief and how we cope, and that ability to be able to tell the story and tell a narrative to try and help, make sense of that. This example about witnessing the imminently dying is quite profound. We'll just sort of read it out. Part of it, then he became calm. A short time before he did his last breath, he opened his widest eyes, looked at me, looked through me into the roof. I told him that now the time has come, and he died in my arms. It's a real intimate personal moment that's been shared within the code questionnaire. The third type of free text was about self-revelation and either sharing information about the impact that, say, poor care has had on the individual's own health, or sharing about how they're coping with bereavement. A previous study that I undertook with colleagues Alison Germain and Barbara Jack, also using the code questionnaire and interviews about how they had found completing the questionnaire, to provide some insight about the motivations that people may have for completing bereaved relative survey. As I mentioned, an opportunity to share the narrative, but sometimes it's also about a search for sense and meaning from the loss, which is in keeping with Niemeyer's theories of bereavement and grief, that some people are really looking back and looking over what has happened to try and make some sense, to try and find some meaning from what they have experienced. Another example of bereavement theory is about the oscillation between loss and restorative orientations. That people can be conducting the interview witnessed that the bereaved people became very emotional and upset, and it was very real experiencing this again, but then were able to gain composure and wanted to contribute to the research. And that could reflect the patterns that we often see during bereavement of people experiencing grief. So then finally, how do we use the feedback to improve care? In the international study that I talked about across the 7 different countries, we used the key issues that were identified to undertake specific quality improvement projects to try to use that feedback directly to make a difference to care. So that was using specific feedback. It involved time and planning, and then some assessment of trying to see what difference it made. The main areas that came up were aspects relating to bereavement support, communication, how organisations operated, or specific education. And examples of this were in Argentina, where a handover tool was introduced to try to get better communication and symptom control for those who were recognised to be dying, as symptom control was recognised to be a key issue in these hospitals. Alternatively, in Germany, for example, they use the feedback to influence specific education, and particularly for undergraduate medical school students. I myself have looked at what the impact of code has been by sending out a very brief survey to people who have expressed interest in using code. The key areas where it seems to have impact are sort of in training and education and implementation, where code has been able to use as an incentive to kind of lead the introduction of specific training, in this example, spiritual care, or using it to kind of nationally think about it needs to be integrated so there's an ongoing quality assurance process, a little bit like what Peter was referring to in his talk, where the quality care is benchmarked and used to monitor about improvements and initiatives. The second impact is in terms of the communication, and particularly for the aspects about hydration, introducing aids or leaflets of ways to communicate better about these pertinent issues at end of life. The third way was mainly about the support of relatives, and that could just be quite general to make it more of a priority, or lead to specific practical changes. So in this instance, where people were able to get car parking tickets or refreshments, so that when they were staying with their dying individual, they were able to be supported on a very practical way. So in summary, I think there's a large expansion in surveys conducted with bereaved relatives. There are many tools, and code represents one that is internationally validated. By using these tools, we learn both about the broad aspects of care, and we can see that communication is a key issue and it can have an impact on place of death. But equally, by including the free text, we get a much more detailed picture of experiences and can use this additionally to think about how we need to improve our care. I've touched on potentially some of the motivations that individuals may have for participating, and think that this is useful in terms of obtaining ethics approval, or if there's concerns about work in this area, that actually it can have some potential therapeutic value, and that people should be offered the opportunity to decide. And then thinking about how we use that feedback to influence care, thinking about the time that's needed, how we use it specifically, and thinking about the plans we need to put in place to actually make that a change in practice. In Christina Gerlach's paper, and just to finish on, this was sort of the message of what we thought from all the feedback that the bereaved relatives wanted to tell healthcare professionals. That they appreciate when we support them, that when we act professional to preserve dignity, relieve symptoms, and to know our patients well as individuals. They appreciate when we look after them as well as the individual patient and keep them informed, and that it's often the small things that make a difference. And I wanted us all to remember that if we are healthcare professionals, we are important and we have a significant impact on that care and that experience that lives on in the bereaved individuals. I've put my contact details there, and as well as potential questions. If you wanted to share in the chat one thing that you would take away from this session, that would be really helpful to see and to feedback, to know how the two presentations have been in terms of this topic. Thanks very much.
Thank you very much, Catriona, for this very informative and interesting presentation. And now we have some time for questions and discussion. And I would actually start with the first chat question from, I guess, our group at Erasmus. Why are bereaved relatives only included in the third step of your, what shall I say, model, or Peter in Australia?
Yeah, that's thank you, Agnes and colleagues. That's a very pertinent question. I should just perhaps convey more clearly that the notion of the levels, it could be up to the individual hospitals to choose which level they want to embark upon. So there's nothing to stop a hospital or a unit for that matter going straight to level 4. So they don't necessarily have to start off at level 1. I'd love to have the bereaved carers involved right from the outset. So I don't think that's something that couldn't be accommodated. But the intent is that each unit or hospital would actually discern which level they would want to start off with. But I concur 100%. It'd be good if that was uniform. So thank you.
And maybe you could go on with the next question, whether you think this will be different for non-cancer patients with other diagnoses.
Yeah, my suspicion is that the framework may not necessarily be so different, but it's about the implementation. So, I think that we're preaching to the converted if we're trying to implement this, for example, in our own hospital, the palliative care unit and the oncology unit and so forth would I think embrace this framework in the most part. We'd obviously have to do some work around the resourcing of this and discern, which level the units want to start off with. But I think that would be potentially more complicated in general units, in non-malignant care and so forth, where deaths may not be as frequent and perhaps there isn't necessarily consideration undertaken perhaps with regard to expected deaths in those contexts. So there could be some challenges, but I think there would mostly be in education, resourcing and convincing, I suppose, some of those other units about the importance of the appraisal of the quality of death and dying in their units. But the actual framework, I think, would still be, my sense is, by and large, applicable.
Thank you. I thought Frank Elsner's hand, did you have a question?
No question, just applauding.
I see. Good. Thank you. I have a question regarding the use of code as a routine use in a clinical setting where you're not doing research and you're not writing publications or studying, or what is your experience and what is your knowledge about that? How much and how is it used in an ordinary setting, in a hospice or palliative care unit?
Yeah, thanks for the question. I mean, it can be used. I guess I've focused mainly on the research evidence, but yes, some organisations do use it as a routine part of their ongoing assessment. I know certainly in Manchester in England, for example, they use it routinely. Whatever way you use it, I think the key thing though is thinking about what you do with the results. And I think that if you're asking people to share such sort of personal experiences, I think it's really key that you've got a plan in terms of, well, what will we do with it? What difference is it going to make? And actually in terms of that moral obligation to the people who have participated, you know, doing something with it. So it doesn't necessarily have to be within a research study, it can be clinically, but I think the question's always got to be, what will you do with the results and how will you use them? And
how long time after death do they contact the bereaved relatives with this?
So in the research studies, we've done it as close to 6 weeks after death. I think often it has been more like 3 months in some of the other studies that have been conducted, and certainly Voices, which was used in the UK, was 3 months after death. I would say ideally, if you're in a clinical setting, it's trying to be proactive about how letting people know this will come. And so that if you're able to approach them at the time of death and say, we routinely send this out, I think that helps in terms of engagement and such like. And so it's not a shock that when it does kind of be sent out kind of thing. I think it's trying to kind of engage people early. This is a routine part of what we do in this organisation.
Yeah, thank you. I was also thinking, I have a lot of questions, but I really encourage you to, all of you, to comment or to take the chance to talk to Peter and Catriona. But I was thinking about when you try to get closer to the quality of dying, you have different perspectives. And of course, it's difficult to ask the dying person because of cognitive failure and a lot of things that is, and fatigue and so on. But so you can ask bereaved relatives, and you get a lot of information on the patient situation, but also on the family situation. But in your Australian model, you also have the input from staff, don't you?
Yes, that's the intent. So I suppose it's three-pronged. So there's the feedback from the healthcare professionals who are involved in the care of the patient, and ideally care of the family, the feedback from the bereaved carer, but also the medical record. So we've suggested that be introduced as well, and that the specific elements in our national standards be utilised as a means by which to perhaps discern from the medical record whether certain things were actually undertaken in the lead up to death. And there's other things outside those accreditation standards that you all know that are pretty much sort of standards, you know, expected in terms of quality of end-of-life care. You know, was it an advanced care plan, you know, offered, and was the care of the dying pathway or something similar implemented or offered? You know, was the inappropriate interventions avoided, et cetera, et cetera. So some of those things would also be considered as the things that could be assessed within the medical record, or also via feedback from healthcare professionals. So I think it's that sort of triangulation of feedback and consideration. And I think we can only do our best, obviously, as you've said, Carl, we obviously can't get it from the patient themselves. But if we can do something, I think, not only locally and it's not about, for our intention, it wasn't about ticking boxes or just meeting the accreditation standards, it's about actually improving our care as well. And we know that in Australia, certainly from the feedback we had as part of our project, a number of the complaints that are actually made within the hospital are actually linked to perhaps inappropriate end-of-life care. So some of the complaints that come from bereaved carers are actually around the quality of care. So we could actually enhance our quality of care, then some of the complaints within the hospital system would also lessen. So there's a number of reasons for things like this that could be useful. And of course, one of the challenges is that those units working with these kind of measures are those who are already on the forefront, and those with a lot of dying patients not interested will not use this. And so we need to find a way to share this
sort of information and knowledge in a more general sense, because you would never have all units in the hospital using them, I guess. We have a new question here from Agnes and her group to Catriona. Do you have an advice on whether the code should be used in a personal meeting, telephone, online, etc.?
So what I would say to that is I would use it in as many different ways as you can to try to meet the needs of that individual, really, because what suits one person may be different to another. So trying to ensure that it's almost got as an inclusive and wide approach as possible would be what I would ideally recommend. It often will depend on the resources and the practicalities, really. You know, why so many of these are conducted as sort of paper questionnaire surveys is because cost and time factors, and that the Voices study did do a comparison within the UK about postal survey versus sort of interviewer, and didn't find out a huge difference in terms of response rates. But I think moving forward, being able to do it more than one way would be helpful. I'd also just say from our international code study, obviously cultural factors came into play, that some countries just didn't have a reliable postal service, so it wouldn't have been practical to do that. But I would certainly say, yeah, opening it as wide as possible would be my recommendation.
Okay, thank you. So by this, I think we should thank you very much, Peter and Catriona, for very interesting and inspiring presentations and projects behind the presentations that we can take forward in our own settings, hopefully. And I will now try to share the screen. And say thank you to everyone. And for those who are not already members in the International Collaborative, I encourage you to go to the web page and get registered as a member of the Collaborative, because there's so much happening in it. We have access to several major international research projects within care of the dying. And we have interesting summer school activities in Malaga, an annual symposium in different parts of Europe. And we have, you know, with this 1040 model that also Peter talked about in the publication, there is a quality improvement framework and toolkits to audit care. And we have a bi-monthly newsletter. The next webinar is in June, Thursday, 8th June, at the same time. This is British time 12, with European time 1 o'clock. And it's how to assess palliative care needs. Should we be taking a more creative approach? So one of them is about using the SPECT to identify people with palliative care needs, like Dr. Christy Boyd, and palliative paramedicine, challenging perceptions, building paramedic capacity, and embracing integrated models of care by Mrs. Madeline German. And I hope you will register for those and join us for the next webinar. And thank you very much for today. And bye-bye.